Welcome back to the Deep Dive. Now, if you're an emergency medicine practitioner here in the UK, you absolutely understand that constant, intense pressure.
Yeah,
It's unique to your field.
it really is.
So today, our mission is really focused on you. We're aiming to cut through all the formal structures and synthesize the why. What's the official and maybe the philosophical definition of a modern EM consultant in the NHS today?
Mm.
We're going deep into the core principles, the competencies, and crucially, that specific mindset required. We're drawing directly from the RCEM curriculum and insights from experts in the field.
And I think we have to start with just the sheer scale of things, the environment you're being trained to lead in. It's not just demand, it's escalating demand. It's fundamentally reshaping what the consultant role even is.
Right.
Our sources show UK ED attendance shot up by 12.2% in just one decade. That's single figure. That's really the core driver behind why the training has to be so robust.
Wow, 12.2%.
And put it this way, every year, roughly 1 in every 2.4 people in the UK will turn up at an ED.
1 in 2.4. That's staggering.
It is. And that kind of pressure, it demands a capability level that's, frankly, far beyond just traditional clinical skill.
That really sharpens the focus on the scope of responsibility, doesn't it? The consultant's actual remit?
Absolutely.
The RCEM curriculum, it's not training someone for one narrow specialty. It's building leaders. Leaders who can provide 24/7 strategic and clinical care for everyone. All undifferentiated patients, the whole spectrum of acute illness.
Yeah, all comers.
Exactly. So here's what we're taking away from this. The consultant's professional identity, as the RCEM defines it now, it's explicitly about being a strategic executive. You're running a highly complex, high-risk service unit. You're not just the most skilled clinician there anymore.
That's a huge shift.
Okay, so let's unpack that. This robustness in training. Given our audience knows the structure pretty well, let's focus on the strategic drivers behind it. Why does the mandate have to be so comprehensive?
Well, it really boils down to relentless volume combined with ever-increasing complexity. You can sort of condense the specific numbers into two main connected drivers.
Okay.
First, that sustained growth, that 12.2% increase. It means your average EM department is absorbing the equivalent population surge of a small town over a decade.
Right.
Often without the same level of increase in resources or, physical space. It's just relentless pressure.
And like you said, it's not just more people. It's patients needing far more complex care.
Precisely. That's the second driver, and it's demographic. The data is really clear on this.
Mm-hmm.
A huge part of the rise in attendances is driven by the growing group of older patients. Patients with complex, often multiple comorbidities.
Yeah.
They attend the ED far more than any other group. And that shift, it immediately demands really intricate care coordination, consultation, that kind of thing.
Makes sense.
And then layered on top of that, you've got the role expansion itself. The modern consultant, they have to provide strategic leadership. They set the department's culture. They take on vital teaching, supervision, admin.
A list goes on.
It does. And the expansion of the multidisciplinary team, your physician associates, advanced care practitioners, that's essential, of course. But it also adds to the direct supervision load and the professional accountability that ultimately sits with the consultant.
Which logically leads us straight to the professional blueprint itself. The 12 specialty learning outcomes, the SLOs. These define what a consultant has to be entrusted to deliver when they get their CCT.
Yeah.
And this isn't just a checklist of skills, is it? This is the RCEM fundamentally redefining the profession.
Absolutely. And what's really interesting is how the RCEM groups these SLOs. They talk about the 4 pillars of consultant practice.
Right, the pillars.
And that structure, it fundamentally highlights that the non-clinical stuff, the strategic duties, they're just as vital for actually delivering the service as clinical mastery.
Right.
You've got to master stabilizing patients and managing the service simultaneously.
Okay, let's look at those pillars then. But maybe analyze the intent behind them rather than just listing titles. Pillar 1 is the absolute core, comprehensive clinical care. What's the scope demanded here?
It basically demands total coverage. That all-comers principle, but applied to every single age group, every physiological state.
Through everything.
Yeah, everything. From caring for physiologically stable patients, which still needs high diagnostic skill across a huge range, right through to identifying, resuscitating, stabilizing the critically ill adult.
Mm-hmm.
And crucially, it mandates expertise in acute injury, so trauma, and importantly, caring for children. All ages, including those with really complex needs. It's basically the ultimate clinical safety net for the entire NHS.
Okay. Then Pillar 2 moves into procedural and situational management. This feels very grounded in the day-to-day reality of EM practice. High pressure, lots of procedures, unexpected chaos.
Exactly right. This pillar acknowledges that consultants aren't just thinkers, they're doers, operating right in the middle of that chaos.
Right.
So pillar 2 covers the technical side, delivering core procedural skills, but also the crucial non-technical skills, dealing with complex, challenging situations.
Like what specifically?
Well, things like managing violent patients, handling tricky ethical dilemmas, capacity constraints, which is huge, dealing with unexpected mass casualty incidents. It sort of encapsulates the logistical and the psychological toughness you need.
Okay, that makes sense.
Yeah.
And pillar 3, this seems to be where that strategic identity really takes shape, departmental leadership and management. For listeners maybe aspiring to be consultants or registrars now, this feels like the biggest step change.
It absolutely is. It's that shift from being primarily a clinician to being an executive in many ways. This covers the essential leadership function, leading the entire ED shift. That means taking command of clinical flow, allocating resources, ensuring safety for the whole department, all under intense pressure.
Not just your own patients.
Not at all. And then there's the wider stuff. General management, administration, broader leadership duties. If you think of the ED as a sort of high-risk company,
Yeah.
the consultant is effectively on the C-suite level, responsible for the operational output of that whole acute care section.
That's a powerful analogy. Okay, and finally, pillar 4, education and professional development.
Yeah.
This seems to cement the consultant not just as someone delivering care, but improving the service and mentoring others.
Yeah, it underpins the other 3 pillars, really. The consultant has a specific duty to support the whole ED team, answering clinical questions, making those tough, defensible decisions under uncertainty. They also have to support, supervise, educate others. And on top of that, they're mandated to engage in research, manage data to actually inform practice, and drive continuous quality and safety improvements.
So you could be running a rhesus bay
Yeah, while teaching a registrar.
and analyzing metrics for a new pathway all at once.
Pretty much. The modern consultant role is incredibly multifaceted.
That progression moving from managing one patient to managing the whole service, it's clearly mirrored in the training pathway itself. Let's just quickly touch on the 3 competency stages, because they give that context for supervision across the department.
Sure. The training is deliberately designed to systematically broaden accountability. So core training, that's usually about 2 years, often within the ACCS program.
Right, ACCS.
The focus there is quite narrow initially. It's on the individual adult patient. The main goal is getting really proficient in advanced airway and circulatory support skills for sick adults.
Yeah.
Basic life support on steroids, essentially.
Got it. Then comes intermediate training, typically 1 year. The focus widens here.
Yeah. This is a really crucial pivot point, clinically and psychologically. Well, the focus shifts immediately to pediatric EM skills, and the trainee starts taking on initial leadership roles. But the big thing is, there's a defined entrustment point here.
Entrustment point.
By the end of intermediate training, the trainee must be formally entrusted to function safely as the most senior clinician overnight.
The overnight shift lead.
Exactly. That moment when you first take on the acute overnight risk for the entire department, that's arguably the real psychological leap from trainee to leader. The stakes just feel immense.
I can imagine. And that leads directly into higher training, the final 3 indicative years. This is about mastery and strategy.
Yes, exactly. This is where you really hone those administrative and strategic skills. The key competencies become about mastering leading the entire ED shift, not just overnight, but running the complex daytime dynamics.
Right.
Managing multiple challenging cases concurrently. And really embedding those administrative, teaching, supervision, and research skills we talked about in pillars 3 and 4. The trainee has to show not just competence, but genuine resilience, the ability to handle overwhelming cognitive load.
Okay, so this feels like the perfect point to connect the structure of the SLOs, the training stages, with the underlying philosophy. We need to move beyond just the curriculum documents and look at that unique EM mindset, the thing that really differentiates this practice.
Right. And the core concept, as our sources frame it, is playing not to lose.
Playing not to lose. Explain that.
Well, the fundamental philosophical priority in the ED is different from, say, primary care or an inpatient ward. It's not primarily about finding the most probable diagnosis quickly.
Okay.
It's about actively making sure that serious, life-threatening diagnoses are not missed. That inversion completely defines the clinical risk appetite in emergency medicine.
So even if the pretest probability for something like a PE is, say, only 5%,
Yeah.
in the ED, you still have to proactively work to exclude it. even if simple musculoskeletal chest pain seems way more likely.
Absolutely. It means you're actively hunting down and ruling out those rare but critical conditions, the zebras, even when they seem unlikely based on initial assessment. It's a high sensitivity approach, and it's operationally very demanding.
Hmm.
There's a great quote from Dr. Graham Walker that sums this up. He said something like, "In emergency medicine, we don't spend most of our days saving lives, as most people think. Mostly, we try to predict risk, especially in gray zone patients."
That's really insightful because it highlights that the real heavy lifting is managing uncertainty. Sir William Osler's famous line comes to mind. Medicine is a science of uncertainty and an art of probability.
Exactly.
The EM consultant lives right at that sharp edge of uncertainty every single day.
And that's where the operational pressure really bites. That need to play not to lose, it can often lead towards defensive medicine, can't it? Well, using tests that have high sensitivity but maybe low specificity, just to be absolutely sure. But that eats up departmental resources, scans, beds, consultant time for follow-up and interpretation.
That's a really critical point. So given that this playing not to lose mindset, while obviously clinically necessary for safety, demands so many resources and increases cognitive load, how does a consultant actually sustain practice? How do you avoid burnout in that environment?
This is where the curriculum, interestingly, brings in this framework of core professional virtues. They're seen as essential for both psychological and professional resilience. It's the HHI framework: honesty, humility, and integrity.
HHI, yeah.
This is basically what allows you to navigate and maybe even survive in that high-stakes, high-uncertainty environment.
Right. Let's break down the practical application of those three. Honesty.
Honesty is kind of twofold. First, it's about being honest with yourself, recognizing the limits of your own knowledge. That means actively seeking help, getting timely referrals when needed. And second, it's being honest with the patient about the diagnostic uncertainty that often exists in the ED. We can't always solve every puzzle in 4 hours, and being clear about that manages expectations, prevents overpromising.
Okay. Humility.
Humility is about recognizing the inherent potential for error, particularly in a high-volume, high-pressure setting.
Mistakes can happen.
Exactly. So it means keeping an open mind, actively seeking advice and support from the entire team, nurses, juniors, other specialists, and, crucially, being willing to be proven wrong sometimes for the patient's benefit.
Right. And the last one, integrity. That must get tested daily when capacity is zero and the next ambulance is bringing someone critically ill.
Integrity is your moral compass in those moments. It means consistently acting in the patient's best interest, especially when you face complex decisions that might mess up departmental flow, breach targets, or really strain capacity. It's about ensuring that playing not to lose philosophy is applied fairly equally to every single patient, no matter the logistical headache it might cause. Sticking to HHI really is what enables clinicians to make defensible decisions under pressure and maintain their professional resilience long term.
So pulling this all together then, what does it mean for you, the UKEM practitioner listening? Our deep dive today confirms that the modern EM consultant role is this really sophisticated, carefully built matrix. It combines high-volume, undifferentiated clinical expertise with strategic departmental leadership, those 4 pillars we talked about. And it's all governed by this unique philosophical approach centered on eliminating risk rather than just finding the most likely answer.
Yeah, the synthesis seems clear. The consultant's job demands mastering the clinical SLOs, yes, but also strategically leading on the non-clinical SLOs.
Right.
And underpinning all of that is the psychological governance you get from honesty, humility, and integrity. This whole model, it feels engineered to handle those millions of attendances each year and the immense complexity that comes with them. It's like the professional blueprint for both survival and excellence in what has to be one of the most demanding settings in the entire health system.
Which leads us to a final thought for you to consider. Given that the core EM mindset prioritizes actively excluding rare life-threatening diagnoses, that whole playing not to lose idea, how does, or maybe how should, this core philosophy shape resource allocation and clinical pathways outside the immediate ED shift?
Oh, interesting.
Specifically, thinking about those administrative and strategic roles outlined in Pillar 3, especially SLO 12, management and leadership. Does the required clinical urgency necessarily translate into needing administrative, well, maybe aggression when it comes to securing resources for the department?
That's a tough question.
Something to perhaps mull over on your next shift or when you're in your next departmental meeting. We'll leave you with that.